Afternoon, everyone. Maybe good evening at Bangladesh and good morning as well in England to all our friends. This is the webinar which we have planned. Webinar.
Yeah.
So this seminar, which will be the first of its three seminar. Uh, I think I've muted myself. Yeah, don't have to help me out too much. So this is the first of the three seminar, of course, trying to find out what exactly had happened and not much on why it has happened. We all know the reason, but what solutions we can offer. This seminar is particularly dedicated to the people whom we have lost in the first part of the onslaught of this pandemic. Many of them we don't know. And with this surge, the virus has come in our own doorstep. I don't see any family which is not affected. We hear all kinds of stories, horror stories related to our friends, related to our relatives. So the pandemic is now not any longer a distant thunder, as we had thought initially during the Wuhan kind of when it started. And then it came in our country and it affected all the service providers. And it was a distant, it was not related, we were not relating to that. But this surge, we are relating to it. So this seminar is dedicated to them, our young doctors.
Hi, sir.
This is to all our young doctors who have been working so hard in tertiary care hospitals, to our unglamorous kind of primary care physicians, both in this urban rural region, in our occupational health, dedicated to the managers who are trying to set up processes and infrastructure at a breakneck speed so that we, the healthcare professionals, can work and try to save some lives. It is dedicated to all of them. We have with us three very eminent panelists, and the fourth one is hiding, but she will also come forward at the end of our last seminar. That is the third one. They are all thought leaders and they belong to the appropriate medical profession who should be in charge of handling this pandemic. I have with me Dr. Rajesh. If you can mute yourself. So we have our first panelist, the eminent Dr. Professor Sundaraman, who has spent early part of his career in this very, very eminent medical university, JIPMER, as professor of medicine for 12 years and was rightly picked up by the government of India to head many such departments where he contributed a lot towards healthcare services, developing policies, participating in various committees as a chairperson. And his last assignment with the Government of India Healthcare. He was the founder chairman of National Health System Resource Center, which is the technical arm of the National Health Mission, the important health mission which the Government of India prides about. His last assignment, of course, after he retired from the government, was equally important, if not more important, as a director of Tata Institute of Social Science, author of many books and research, internationally known figure, Professor Sundaraman. My next speaker would be Professor Sita Naik, who is an authority and in the country and outside as well on immunology. That's where it's the fundamental thing which this virus is attacking. And to know what are the changes taking place in our body, in the immune system, we decided that Professor Sita Naik should be our second panelist and should follow Professor Sundaraman. Her early career, she was in Amchi, Mumbai at St. GS Medical College of KEM Hospital. And later on, she was Dean of Sanjay Gandhi Medical College in University of Lucknow. She later on joined as a fellow member Board of Governors in the first Medical Council of India Board of Governors in 2010 and 11. She was responsible, along with my colleagues in that committee, to develop the reforms in medical education, both at undergraduate level and the postgraduate level. She is the author of the Vision 2020, which we developed in way back in 2010 and 2011. So welcome, Sita. And of course, last but not least is Professor Rajesh Dere, who is our front man, who's in the thick of the operations in Mumbai right from day one. And I have no hesitation to say that the Mumbai city is best prepared during that time and even now to face this surge which has paralyzed the whole country. We don't have any dearth of oxygen. We don't have any dearth of hospital beds. And thanks to people like Professor Dede, who has been in charge of this ingenious jumbo tents, which were all erected at a very, very short notice for treating the people, large number of people, and later on converted that into a vaccination center. He is professor of forensic medicine. He is the professor and secretary, and he has been in education of medical legal services. So he is another right person to address this issue. We at HealthSpring, we have chosen the right people to participate in this seminar. The whole seminar is not meant to find fault, but to find possible solution and to help the government of India with this unsurmountable kind of problem what we have now with the huge population. With these words, I invite Professor Sundaraman to give his presentation.
Thank you.
Sundar.
Soumya, is it possible to present?
Yeah.
Yeah.
Just 1 minute, I'll share your presentation.
I won't go through all the slides because that will take too long. I'll take only 10 minutes to look at it. And so I will skip a lot, but I wanted to show some initial slides and then we will move on. Yeah, right. Well, thank you. I thought I would say a few words on understanding the pandemic and the role of the scope of the general practitioner. And I think I will take some 10-15 minutes to start my introduction and then come back on that. So next slide we can go to. Next. Now we see this pandemic picture, right? And I think we are familiar with it. The first wave now looks almost like a pilot program. At that time, it was such a big threat, and 1 lakh seemed an enormous figure. It has been dwarfed. It has been dwarfed by the second wave. And the second wave, we are now today still going higher and higher, and we are now reached 4.14 lakhs per day, plus more than 4,100 deaths, which is one of the highest number recorded deaths per day. And it is certainly going to increase further. And we don't quite know where it will stop, but hopefully there are many predictions that are more hope that towards the end of this month it should come in. Next. I just shown the whole South Asian scene. And you can see that in some ways it's not dissimilar, but we shouldn't also stress exactly how similar it is. Now, if you look at Bangladesh, which has the highest peak, which has a relatively small wave in November, which is later than our wave, but it has a big peak before us and then has subsided. But if you look at Pakistan, it has 2-3 other peaks also which are going in. An early sharp peak and the second peak has been smaller with something of a small wave in between. The point I am trying to make in this is that there are waves. Sri Lanka has actually shown much smaller waves, but this is also because of the size of their population. And I've taken India out of this because if you put India in, the rest of it gets dwarfed. You can't show it on scale. I'll show you one picture to give you a sense of that. But the simple point I'm trying to make is that the pandemic comes in waves and there is no predictable or fixed pattern of the waves. And there are second waves, third waves, there are second is larger, second is smaller, many different patterns. Next. So that's the Bangladesh one at the bottom. That's the same graph as the earlier one, but once India is shown, then on scale, the rest get dwarfed. We could make it per million and bring it out, but that is also confusing. The only reason I'm trying to show is that actually India's is a humongously larger wave in terms of absolute numbers. But the patterns are, there are similarities between the patterns. The main similarity being it occurs in waves. Next. Now, why do we have a second wave? One of the most popular explanations is the mutant strain. There have been many mutant strains described, the UK strain, then the so-called double mutant strain from Maharashtra, and now there is another strain that is being now accepted as an Indian strain. Now, is it the explanation for the second wave? Yes and no. I am a bit cautious about calling it the explanation. Why? Whenever there is a pandemic, there are strains, there is a particular virus spreading, it is always mutating, and there will be some strains that will form the larger proportion of what has spread. To give it a causal significance can be confusing. Like in any ecosystem, there are a number of birds and animals, but one animal may become the dominant species because it has some advantage in its fertility. Then it dominates, but that is not the same as saying cause. So to what extent is this the cause and what extent is it an association? that definitely the strain that spreads is more infective. But on the other hand, is it the cause? Implying if this strain was not there, there would have still been, and you can see in different parts of India, different strains are also contributing. Now, if it was a reinfection, if people who were earlier infected are getting reinfected, and that is accounting for a large part of the wave, then the mutant strain can have a greater causal relationship. Or if it is a breakthrough vaccination, then of course. But that we are not seeing. Reinfection, thankfully, is a minor thing. So I'm a bit cautious about calling this the main cause. But one point I want to make, because I don't want to come back to mutant and genome, that genomic mapping is very important. And you have to constantly keep looking for something called a virus of interest. That's a very rough, broad set of viruses. Amongst them, we focus in on viruses of concern. And then we identify what are the immune escape ones, and which actually means that even the past infected can get reinfected. Why is this important? Because the way India is going about it, we may immunize a sizable part of our population over time, but it will continue to circulate in the remaining population. Therefore, a mutant strain may develop in the remaining population, which may go beyond being a virus of concern to an immune escape virus, which means it will no longer be held back by the immunization we have given or past infection. Which means you can have, despite full vaccination, despite vaccination, you can get reinfected. That's a dangerous scenario. And the one way to prevent it is to really push for universal vaccination. But that's one of the reasons why genomic mapping is also very important, and why I'm not at this point of time giving it a causal significance for the second wave. The second thing. Next. Now, the other common explanation given is because of people ignoring physical distance. Is that true? Yes. In fact, there can be no disease spread if you have taken 100% precautions in a sense. But that's not really saying too much. Because after all, in November 2020, it declined. There were elections in Bihar then, there were festival seasons, there was loss of social distancing. And this time, definitely election rallies and Kumbh Melas have amplified and accelerated the spread. But it has spread even where there were no elections, quite independent of the place where there were elections. And you could see that at some point, what we are saying is while physical COVID-appropriate behavior reduces the risk of infection, it does not eliminate infection nor the phenomena of waves. And therefore, while we won't deny it, it is not enough to give us an understanding of how we should understand waves coming and going. Next. The point about it is that waves are not inevitable. New Zealand did not have a second wave. It had an outbreak. Vietnam did not have a second break. It had an outbreak. China has had outbreaks. And the difference I'm making between outbreaks and waves is that outbreak is a very focal event. And then once it is identified and contained, then it does not, it remains contained there, it doesn't become. Whereas in a wave, there are multiple clusters across the country, which each of them cross a threshold and go into pandemic behavior. That means the RO exceeds a particular number. And these multiple clusters fuse, then you have a wave, as different from outbreaks. And the heart of stopping this is a good disease surveillance system that identifies the clusters when they are small and responds to the cluster. So why did it go down in November? The most convincing theory is that society is not uniform, it is heterogeneous. And within this heterogeneity, there are clusters within whom immunity rises to a certain threshold level, and also supplemented by health-seeking behavior and COVID-appropriate behaviors developing within that social network, within that section of society. So that After a point, these social networks slow down and it actually slows down. But the disease slowly seeds into other villages, into other bastis, into other apartment blocks, wherein slowly it develops again and then crosses a threshold. So it is because of the heterogeneity of society and the nature of the spread of disease according to clusters, which are not necessarily geographical. There's an overlap with the geographical, but these are social network clusters that you can have this rise and trend. And therefore, the main lesson of it is you can get into a third wave also, because this will subside and then you can get again, and many have had 3 or more waves. And at some point, we must remember these waves are preventable, but prevention requires a good disease surveillance. One of the problems with good disease surveillance is that there is not only a supply side, not only what the government has to do, but a huge amount of stigma and denial in society means that people don't come forward when it is at a low level. And therefore, you have another problem that will go on that. Next. So this second wave is much more rapid in its acceleration and growth than the first wave. People talk of clinical differences, and I'm sure you will discuss this much more. But as a proportion, I'm not sure whether we are having greater, though in absolute numbers, you will see much more diarrhea, much more of other types of symptoms. And this is about mortality in the younger age group also. The younger age group, it was about 21%, it becomes about 25% of the 18 to 45 group. This is very marginal increase in the proportion of younger population who get affected. But because overall the number of diseases or incidents has really shot up, you will in your anecdotally, in terms of common experience, know of far more people who are young and who are being affected. Similarly, with mortality, we don't really know that case fatality rate is higher, but there is no denying a huge increase in deaths, especially as our systems are failing to cope, and oxygen and intensive care is really in short supply. What you are really having is a mortality, but we are really not, it's not necessarily attributed to the virus, but basically to the large number of diseases. So we have a problem of a different magnitude, definitely. Next. And therefore, stopping the supposed third wave requires countrywide integrated disease surveillance. We need to engage with communities. We need to engage with the entire health sector, public and private, and we need to roll out universal vaccination, achieving high coverage soon. It's too late to stop the second wave. The second wave, even if we vaccinate everybody tomorrow, it's not going to kick in before August. We will 2 rounds and then the period. But hopefully we will be in time to prevent the third wave. So in some sense, the larger issue is of a set of activities that we will have to sustain. Next. Yeah, here I just wanted to deviate and to get into a little bit of emphasis on what the general practitioners' roles are or possible. This is something that we are. One basic principle we need to understand in healthcare as a commodity, as different from every other service, that this simple division into producers and consumers is not appropriate. It's not that health is provided by hospitals and doctors and consumed by people. In fact, people are co-producers of health. They are partners in their own health. Health is something that is manufactured, if I may use the word, at the level of the family, the household, at the level of the community, and the hospital is party to it, but it is a guide in it, but it is not really there. Which means that we have to think about this with a much greater role for communities and primary care in this. The second thing is, when we go around blaming people's behavior, we must understand that individual behavior is a socially conditioned phenomenon. It depends upon the culture, tradition, practice, knowledge, and therefore it has to be addressed in more ways than just the point-to-point communication. And you don't get much purchase in change in behavior. So if people are not wearing masks, if people are not following these rules, somewhere we have to say that as a system of healthcare, we own responsibility for being able to failing to persuade them. Next. And therefore, the GP has a role in educating and supporting families on what they can do to protect themselves, irrespective of what they have on counseling, and treatment and support for mild cases and asymptomatic contacts. And what I think is a very important role, sustaining essential non-COVID care. One of the criteria of a resilient system is that you should be able to sustain care for non-communicable diseases through the height of a pandemic. Otherwise, you lose more people to that, and even the pandemic will worsen. Then to reach appropriate public services and specialist services as a gateway to reaching that, and the fight for Part B party to the advocacy action needed for better policy and accountability of government. Also to shape and intervene in the public discourse about the pandemic. So you have this entire set of things that you need to see a person as doing. Otherwise, we may get ourselves confined to point 2. When we are talking of what the GP must be doing as different from a specialist, point 2, maybe a little bit of isolation, but we don't actually see the whole scope of the thing. Next. Now, one thing that I have mentioned, and I want to come back again, is this notion of stigma and denial. Stigma is a sense of shame, a sense of guilt, a sense of abhorrence that you feel even when you get the disease. You hide it. You feel it's something wrong that you have done. It is punishment. It is some penalty. And when others get it, you react with abhorrence, with avoidance, with anger, and usually it piggybacks feelings like caste and class. So you say, oh, those people, they have dirty behavior. Oh, those people, they are not responsible people. It's always you other the phenomenon. There is always an other person who is responsible because he's other, because his practices are different from you of getting. So even doctors were a victim of stigma. Even at some point, Muslims were a victim of stigma. You attributed it, the whole threat, to the Tablighi Muslims and failed to notice the other chains of transmission. So this sense of stigma is provoked by the nature of state response to it. But close to it is the problem of denial. It's a serious problem. At the individual level, there will be people who will say, oh, nothing is there. If I get tested, I'll get positive, so I won't get tested. Or people are just jabardasti, they are calling it COVID-19 because they get money for it. Or this is a big pharma plot. Social media is full of conspiracy theories around thing, which is not so innocent. Because all of them weaken our ability to take sensible measures and to focus on what needs to be done. And even at the community level, at the policy level, you could see the first 4 months, the government went on and on about saying there is no thing called community transmission, made its own definition of community transmission, and claimed success for preventing community transmission. And all that entire discourse means nothing. At some point, transmission occurs, many people, you don't know where the source from, that's community transmission. It doesn't mean anything to the management of the disease. But yet we have a whole discourse of denial that we have controlled it. And this was a very damaging narrative because we relaxed far too prematurely. So this is a larger problem that at some point we need to address on that. Next. When it comes to physical distancing, hand hygiene, think about it when you counsel. There's this little Twitter poems. There are Twitter poems, if you know. We are not all in the same boat. We are all in the same storm. Some are on super yachts and some just have one oar. And it's a longer poem. It says some, but I've just drawn 4 lines from it. But the simple point is, everybody is in this pandemic storm, but we are in very different places. A middle class, 3-bedroom house person with family, and who can work from home on the computer is entirely different situation from a slum dweller where there are 5 people living in a single room, and a simple victim blaming approach. And this is a thing, is not going to really make change. In addition, what has happened is there is a whole of law and order approach. You see this even the anchors are very proud of showing it. The murgi laga diya. The public shaming of individuals for COVID inappropriate behavior is seen as a big solution to getting behavior change done. As public health, we learned about not doing this about 50, 60 years back. To rediscover that we have not learned anything in public health and we have remained ignoramuses, that we think policemen can actually enforce behavior change. How much more stupid can we get on that? But law and order approaches are particularly stupid. The policeman finds the fellow driving the scooter with a mask, when actually the spread from the mask on that time is very little. But then he will get down and start talking to a person or go inside a room or a shop and he will remove the mask, and that time it is very high. But that part doesn't get monitored or fined. In fact, many places looked at our effectiveness by looking at the number of fines collected. So at some point, we need a much better way of doing even behavior change. Next. So that's what is called a public health approach to behavior change, and interpersonal communication in which the general practitioner plays a big role is required. Next. And some of it is simple, what in our old park textbook was called a two-way communication, where you ask the person, can you wear it? Why did you not wear it? What difficulty do you find? Can you practice this? And then discuss with them how they can practice it, distancing, rather than just at some point of time imposing a view. Next. So I think if we were to just sum up this part, it is stopping victim blaming, desisting from a law and order approach, addressing stigma and denial, evidence-based health communication strategies, and engaging with communities. I'm just going to show, can we go off the slides? If I am on the slides, can we stop sharing? Because it will be easier for me to complete the thing. The similar problem we have is the whole area of contact tracing, which is almost not done because people believe it has no role. But if you as a general practitioner look at it and say, look, you have tested positive, and you advise him on what he should do for himself, but you also spend that extra half an hour or 15 minutes or 10 minutes talking to him and saying, okay, since you developed fever, whom all have you been in touch with? Let's write their name down. Before you develop the fever, the previous 2 days, where all did you go? Let's write their name down. They are your friends. They are likely to be your relatives. They are likely to be your loved ones. Can we give them a call and warn them that they may be developing symptoms? And if they have already developed, they should seek testing and treatment. And if they have not developed symptoms, they should quarantine themselves. This is not done because the pandemic will stop. This is done because you can protect your family and make sure the old man in the house or the young child in the house is not exposed. So if COVID-19 contact tracing is seen as a local, or if you're in the village, this is the first case, or it's the first case in the house, or if it's in the first case in the apartment block, there is always a role for contact tracing, which is a way of helping people limit the infection rather than some overall police go and discover who it is and find those things and file an FIR, all sorts of nonsense. This is a simple thing. And similarly, testing. 2 clear indications for testing. Test anybody who is positive, irrespective of the situation, and test people who are anyway, test people who have been in close contact, and close contact, mind you, not passing contact, but after 5 to 7 days of close contact, if asymptomatic. If they are symptomatic, they should be tested immediately. If they are asymptomatic, testing immediately afterwards will lead to a false negative. These simple rules, these simple counseling, half the time I am spending today, if I would say, I am spending 3/4 of my day in responding to friends who are asking me these questions. They are asking me that I have tested positive. whom all should I be tested? Or my brother tested positive. Yesterday I was with him. I traveled with him by car. Should I go and get myself tested? And I say, no, you go and stay at home. Wait for 4 more days. And if you don't develop fever, still go and get tested. If you develop fever, get tested immediately. And that sort of counseling advice at primary care is an extremely important role that we play. Therefore, in this sort of advice, and similarly, the issue of isolation, which is a word I use for positive patients who are isolated, and not people who are not sick but may develop sickness who are quarantined. These ground rules require explanation. They have to be done by people who are counseling, whom they turn to for help. And that is one of the big roles that general practitioners will play in this. Finally, when they fall sick, when their breathlessness is there, then making use of the dashboards, making use of your contacts, getting them admitted on time is a major role that we need to take on and be able to develop the linkages by which we can develop. Post-COVID is another major area for primary care that we have not got the time, but we should need to go into. Perhaps you will need a separate webinar on post-COVID altogether. There's a whole area of issues there and the whole area of counseling. So there is a huge area of work where general practitioners can make a difference in limiting the spread of the disease and in helping those who have the disease. Thank you.
Thanks a lot, Professor Sundar. I wish you could.
Thank you.
I wish you could go on and on and on. That it shows the importance of primary care. It shows the importance of public health, and it shows what the healthcare service is about. So our next speaker is Professor Sita Naik, and on to you, Sita.
Soumya,
Go ahead.
Can you
Right.
share the slides, please?
Right.
Soumya?
Yeah, 1 minute, doctor. I'm doing that.
So I will just give a very simplistic, ultra simplistic overview of the immune system and what, yeah, thank you. So this is, as you can see, the immune system basically, let me start with making one statement. There is this huge tendency for immune boosting. Okay, God has given all of us a very good immune system. So it's like you cannot boost it further. It's there. Unless you have a disease which causes suppression of immunity, or you're taking drugs which definitely suppress your immunity, there is no such thing as boosting the immune system, right? So it is like eating vitamins. If you eat a nutritious diet, you don't need to eat supplements. But there is this whole tendency of eating a whole lot of immune. So we have a very sound immune system. And the initial events when any foreign agent enters our body is that our body is very well competent to deal with it. So in the particular case of COVID, it enters through the nose and therefore through the nasal cavity, and it reaches into the alveolar spaces, and here it enters the bloodstream. Can I have the next slide? Next, okay. And when it first meets the site where it enters, in the case of COVID, it has these surface knobs, and specific proteins on the surface knobs, they recognize the ACE2 receptors on epithelial cells of the lung and the ciliated cells on the respiratory passages. They bind to them tightly, they enter these cells, and they use our cellular systems to replicate, multiply very rapidly, expand. When they multiply rapidly enough, they burst the cells, come out, go into other cells, invade other cells, and therefore they are trying to find a host or a happy home where they can proliferate. Now, when this initial contact between the host cells and these viruses take place, the immediate response of the body is to kickstart what we call the innate immunity. And this is the spontaneous resistance of the body to throw this virus out. And this means bringing to that site a whole lot of cells like neutrophils, macrophages, dendritic cells. And these cells then get activated and they secrete a whole set of proteins which are called cytokines. And if you see this list, you can see they're called interleukins. There's interleukin 1, interleukin 6, interleukin 8, interleukin 12, and tumor necrosis factor alpha. These are among the few of the large number of proteins which are secreted. Besides this, viruses also induce the production of something called interferons. Now, what happens is that this set of actors, these cells which ingest the virus and these cytokines, they are very competent, and in a large majority of cases, they will mount the necessary defense mechanisms to eliminate the virus, which is why 80% of people have no symptoms, right? And this is true for all the things that infect us from day in and day out. We are not falling sick every day. Most of us are fortunate. We don't get infectious diseases, maybe a sniffle once in a while, but we stay healthy because the immune system is very competent in its primordial, primitive knowledge to recognize this foreign agent, which is not supposed to be in our body, and throw it out. Now, if you see this list, and in this elimination of viruses specifically, the interferons are very important. Alpha interferon is an antiviral agent, and there are many other antiviral agents which the body produces. But among these cytokines, you will see, and this is why when the virus wins the battle, and the body is not able to eliminate the virus, then more and more cells come into play, and there is a huge inflammatory response in the lung, which is why all the fluid fills into the alveoli. You have the changes in the X-rays, and this is what we call the cytokine storm. Because of the fluids in the lung, oxygenation is poor, patient becomes symptomatic, fever starts going up, and the more cytokines there are in the body, then these cytokines, they flow into all parts of the body and they have multiple events. In fact, if you look at IL-6, interleukin 6 is what is responsible for temperature, pyrexia. So all these factors then come into play, and you have they are what they cause the very rapid deterioration in the early part of symptomatic patients. And this is what we call cytokine storm. Now, some of these cytokines are also important because, and I haven't shown the full list, there are others which are called chemokines. They attract the lymphocytes to the site of this whole drama. Can I have the next slide? So once this activation takes place, then the T cells also are pulled into this whole fight. And then the T cells, unlike the cells of the early inflammation, which will respond absolutely the same irrespective of which infection enters you, the T cells are programmed to recognize each specific infection. So they are very, very, very targeted. So the T cells which will recognize the COVID proteins and proliferate, they will be specific for those COVID proteins. And they undergo clonal expansion. So they become huge in numbers. And we have two types of them. We have what we call helper cells. And these helper cells are cells which help then the B lymphocytes to make specific antibodies against the virus. And they also help in expansion of another type of T cells, which are called killer T cells, which kill the infected T cells. Next slide. So as you can see, when the antigen enters, there are these macrophages and they help the activated T cell to help. And these then also stimulate B cells to form antibodies. These antibodies can neutralize this virus. The cytotoxic T cells can kill the virally infected cells. And therefore, the whole immune system is like a huge army, which has artillery and air force and navy, all the different branches, all of which are coordinatedly trying to eliminate the viral load. So now it's a battle between the immune system and the virus. And we want the immune system to win the battle. And in this case, that's the only agent we have, because we don't have an antiviral, right? In bacterial infections, we give an antibiotic. There are some viral diseases now, like hepatitis C and a few others, which we are finding antivirals, but we don't have an antiviral against COVID. So one thing we have to remember is that we are not treating this disease. We are only managing this disease. And I think terminology is very important, because people just say, what's the treatment? You cannot treat it, because treatment means you're addressing the actual causative agent, but we do not have anything to fight that causative agent. So what we are doing is to understand the symptomatology and manage symptoms so that the patient comes out at the end of the story having eliminated the virus. So we are helping the patient to use his own immune system or overall defense mechanisms to get rid of the virus. Next slide. Okay. So as we have seen, there are two unique features, or we should remember that the immune system has two very unique features, and these are called memory and specificity. So what happens when we have this expansion of these T lymphocytes and B lymphocytes to recognize a specific pathogen, they expand clonally from 1 to 100 to 10,000 to millions. And once their need is over, they contract. But what we are left with is a very small population of what are called memory cells. And these memory cells are retained in our body for a long time. Okay, so whenever the same virus enters, the body, oh, okay, I've seen this one before. So the memory that is retained in us then causes, instead of the first time it took all those steps for the T cells and B cells to expand, here the T cells and B cells immediately expand and they get rid of the infection because this memory is retained, right? And it is so specific that you retain memory for every different infection or vaccine that you deal with, which is the basis of vaccines. So any disease which once you get it gives you long-term immunity, the vaccine will also give you long-term immunity. But if the disease natural history does not give you long-term immunity, then it's unlikely that the vaccine is going to give you long-term immunity. We have typhoid, we have flu, for which we haven't been able to find vaccines which will give us long-term immunity. On the other hand, we have childhood vaccines, which is protecting the child till adulthood, tetanus, which gives us long-term immunity. So it really depends upon the nature of the antigen. Some infections are not providing long-term immunity, and therefore it is very unlikely that the vaccine will also provide long-term immunity. But what we are exploiting is the natural capability of the immune system to have this very high, rapid antibody and cellular response when it encounters an antigen which it has seen in the past. Can I have the next slide? Okay. So just to recap, in SARS-CoV-2, you have infection through the nasal cavity, expansion in the lungs and in the alveoli. You have this huge cytokine storm with a large number of neutrophils coming into the lungs, activation of the macrophages with release of all these pro-inflammatory cytokines, and activation of the T cells and the B cells. So steroids. And this was the greatest single, I think, thing that came out in the management last year when we understood that there is this immune hyperactivation, because steroids are an extremely effective suppressor of the immune response. But you should also remember that if you have low immunity, the virus wins the battle against you. So giving steroids too early, giving too much of steroids can have detrimental effect, because if your body is smart enough and is strong enough to be dealing with the virus and you suppress the immune system, then you're giving the virus advantage. But the moment the virus has overcome your immune system and is taking off on its own, that's the time to step in and suppress the immune response. So timing of treatment is very important, not always, it's a very clinical thing. Now we are advising a lot of home care. So the role of people who are giving primary care is very important. Putting a person on steroids is critical. It has its own side effects. In the last week or 10 days, there is this huge thing going on around the clinical community about the increase in the fungal infections because of overuse of steroids. So there can be, things which we have to keep in mind when we are using steroids. Has to be used appropriately. Anti-IL-6 is another treatment modality which is very direct, and when the patient is in cytokine storm, can help because it neutralizes the IL-6. Recently, yesterday or day before, I think that is a good piece, a very positive input, that the government has, I think, approved the import of the specific mononuclear and monoclonal antibody, which is directed against the COVID SARS knob protein. It's not like using plasma. It is a specific monoclonal antibody. The Roche antibody license has been given. I don't know how much it's going to cost, but it was a single most effective treatment of early COVID in the United States during the big peak last winter. And they used it indiscriminately. You have to use it really early when the virus is just multiplying and spreading, and it neutralizes the virus and doesn't allow it to settle down. I don't know how quickly it's going to reach the market and what will be the availability, but that is definitely a positive development.
Thank you.
Next slide, just one more.
Sita, the time is running out a bit.
Yeah,
I wish we could go ahead.
If I can do one slide.
Right, go ahead.
So just one slide, and then next one.
Right.
Next one. And then one after this. So this is just to show the different types of vaccines we have. We can maybe discuss it later. Next, this is something Dr. Sundaraman also. So as this is only to re-emphasize that herd immunity, the word herd immunity refers to a large percentage of the population having acquired immunity through vaccination. We have never used it in the context of people getting infected and that causing herd immunity, because we do not know how effective the natural developed antibody is in protecting against subsequent infections. And that is why it is very, very important for everybody to understand that the more people, the quicker we get immunized, get the vaccines into the arms, the better we are going to deal with subsequent whatever ups and downs of this virus. There will be some ups and downs, but if the ups are going to be smaller and smaller, we'll be very lucky. But that will happen only when the vaccine, because the natural infection does not provide the immunity that 2 doses of the vaccine will. Thank you.
Thank you. Thank you very much, Sita. Our next speaker, of course, is Dr. Dere, who has been at the thick of the whole problem right from the beginning and now facing the onslaught. So we would like to know from you, Professor Dere, about how you managed and what plans are there for facing this onslaught of second surge. Thank you.
Thanks, sir. Thank you for the opportunity to speak. Right. Basically, I would brief myself. It was 10th of May when I was posted here as a dean by the guidance of Honorable CM and Principal Commissioner. And this is the first transit hospital of our. It's a purely transit hospital. It's not just like the halls of UNESCO or say Richardson Kudas. It's purely carpet and purely transit hospital. It is 2,320 bed hospital and is only next to the second in the world. So what we did, actually for this transit hospital, why the concept? Because in the May of April, there was sudden surge of number of cases in Mumbai, and the existing private and the public hospitals, say medical college or peripheral hospitals, beds were completely occupied, and there was need of sudden increase in the bed capacity. So if any major hospital was a concern, then I think we have taken much more time. So in Government of Maharashtra and MMRDA, basically, with our technical support of my team, erected this phase 1. We have phase 1 and phase 2, literally within 17 days, 17. And we inaugurated through Honorable CM on say 18th of May. And we took our first patient in 25th of May. And as of now, considering the phase 1 and phase 2, we have treated more than 22,700 cases. So this is in brief about COVID hospital. Everything is given free of cost. What is the role of, I think, Professor Gautam Sen expected from what is the role of these COVID hospitals? After this, after success of this first jumbo, Civil Corporation of Greater Mumbai has erected more than 7 jumbos of 10,000 and now we are for the third phase. The Municipal Commissioner and Additional Municipal Commissioner City, Sri Sanjeev Jaiswal, we are having 4 big jumbos around 6,000. So in this COVID, basically the jumbos have contributed a lot. I would say more than 60% of the COVID patients are treated at jumbo facility compared from last March to April. This is what is in brief, and we have very good statistics. Just share with you. First 10,000 cases of phase 1 have made a good infogram. There was no mortality of phase 1. The recovery rate was not more than 9 days, right from ages 0 to 30 years of age. And literally, we had more than 70% comorbid cases treated. Now we have 108 bed ICU, 12 bed dialysis even, and 800 bed oxygen, and more than 900 bed hospital, PKC and Professor Sen, should I speak of vaccination also?
Yeah, go ahead, please.
Yeah. Now I'll just brief what are the salient features of our, this hospital. That We are the first in India to go paperless. On 4th of October, 4th of September, we had a very good software from I9 Innovations company. Concept is by my team. We are the first COVID hospital I feel in India to do this, and it is so good as it was expected by Honorable Prime Minister that we create a patient ID. Once any patient is admitted, registered number of the legal head, we shoot a message with name, bed number, and a link. Share with you all to this. Just the relative sitting at the home has to browse that link. He has to have Android phone. He has to have internet connection. To that link, he can take all the reports, whatever reports we have, BKC treatment. He can show to his consultant, download that report. He can come back to our control room. Our control room has 8 dedicated 24 by 7 lines, out of which we have 3 assistant consultant of say BDS, BAMS category. We have 4 upper consultant DA, TCH, and MD interact with this for the second OP. Along with this, we are the first in India to have a vital lab. This virus testing lab through CSR is a container lab of biosafety level 3. I think it's not in Maharashtra also. I am attached to SIAN also as a professor and head. So for your information as a forensic expert, but we got it through CSR. And the best part of this is that we really, give reports of IL-6, D-dimer, all specialized tests on the desktop of our consultant boards within IL-6 is 17 minutes. IL-6 is 17 minutes, D-dimer is 18 minutes, and if that link is connected with any mobile of our consultant, that consultant can at home can browse that report and everything. So this has aided us in decreasing mortality at a large, even though after treating 22,000 patients, compare the mortality of 2,328 beds, our mortality is 50% less than the national average. And I think one of the best in country or best in. So that way, this information technology, AI, has helped us in doing this. Third, what salient feature we had, initially, there was a fear for the healthcare worker of not doing calls, being infected, and because first 3 months there was such a fear in doctors, healthcare workers, that they felt that if I am going in ward, I may get infected, family may get infected, and there can be chances of mortality. So with the help of IIT, Indian Institute of Technology, we have 2 robots. One is MedBot, that we can get it anywhere. MedBot for supplying food and everything. Second, what we did, we have some thermal scanners from Germany. That robot will go in the ward of 28, a ward of 28 and 58. And it will sense the temperature of the patient in and around. And once that temperature is more than the normal, it will send a signal here in administrative office where these IIT people are sitting. And only that temperature is checked by our ward boys or sisters or RMs. After this, we had RT-PCR CSR through SpiceJet just 1 month before, and the capacity of that is 3,200 samples per day, that is in 24 hours. And we are really giving reports, even in this period also, we are giving reports in 8 to 12 hours. So this is what some BKC has done, which is, it was not done in India. We have high definition unit. It has no walls at all. And it is only of air curtains, just like in any malls, you see that air curtains white. And it can be dismantled within half an hour, and you can just have to any hospital, and you have to attach with medical air, all the requirements, electricity, and you can have your SDU come ICU. It has HVAC system, single unit. It has ventilators, it has monitors. It's a highly small area, but it can do it. Over and above this, we got a CSR through Adityaji Thakre. We made a concept of container ICUs. 40 by 12 container. We have 5 beds in it. all high-end ventilators and machines we got through CSR. Now I am getting a container ICU from one of the CSR. We are making a special dedicated pediatric ICU. I think it should be the only one in India in container. And I got a CSR donation within 15 or 17 days. We'll see in VKC 12-bedded container ICU with top class anything which is not available in India. So this way, this COVID hospital, we have done such a good thing. We have served the people. Along with this, we are the first, I think, in the country of Mumbai to have post-COVID OPD. Now, as of now, we have
Thank you.
screened. Yeah.
We are running out of time,
Yes, sir.
Professor Dere. We are running out of time. And definitely what you
I
have,
could not hear you, sir.
I said we are running out of time.
Sure, sir.
And
Sure.
definitely what you have done is something very spectacular
Thank you.
and
Thank you.
needs a full webinar on that for
Yeah.
all of us to have some experience of
Can I
what
take
you
you
have
1
done.
minute? Hardly
Right.
1 minute.
Go ahead. Go ahead. Go ahead.
Just I will brief. We have post-COVID OPD. We have done more than 2,500 screening of for all our discharge patients, and none of our patient has come back with severe infection and mortality. We have done free dialysis more than 2,000 patients on OPD and indoor basis, and vaccination. I think Gautam Sen has visited my vaccination center. It is one of the biggest in India. We have vaccinated more than 260,000 as of now. Thank you very much, sir, for giving a minute.
Right.
Thank
So, I asked you that time the question that how many adverse reaction you had out of such a huge number of vaccination, and you said that there was no adverse reaction.
There is no AFI, adverse
Right.
reaction. Yes, there are cases of headache, myalgia. Some people forgot
Those
to
are
take
side effects.
hypertensive medicines. Then after vaccination, they had headache. I think we have a mobile ICU in even observation ward also you have seen. It's a pure ICU setup in our observation itself. No
Right.
need, everything, even though we are ready for anaphylaxis. So what happened in one of the hospital of Andheri, unfortunate event, if there is any anaphylaxis which is supposed to be 1 in 10 lakh, within 2 minutes we can give, say, the defib and everything we have in observation ward. I think Gautam Sen sir has visited it. So we have zero AFI, proper AFI. Go into headache and all these cases, yes, is a known, problem after vaccination, say
Right.
having fever and that cannot be AFI.
Thank you very much.
Thank you, sir.
I must thank all my panelists, and I would like to end this session asking everyone, the panelists themselves, for a 1 minute kind of message, if you can give, that will be great. Thank you. Starting with Sundar.
So you can see from these three presentations, the wide range of knowledge that this calls into command, from a very deep understanding of microbiology and immunology to a large mega hospital and the management of hospital administration in the extreme management, and to a whole area of issues on primary care. And it's very difficult sometimes to keep our track on all that is happening within this area. It's a really challenging area. But we are in a situation and we can act from where we are sitting or standing. So you are, if my audience is largely of general practitioners, then the way I would like you to think about it is, given the hugeness of the problem, given the immensity of the problem, what is it that you can do that can make a difference? And that is where you can think of many things that can be done with your individual patient, but also at the community level at some point. But one of the big problems, especially in urban spaces, has been the difficulty of establishing primary care. Means that when you can do COVID care, but you can't actually maintain all the other essential non-COVID healthcare services. And that requires a large system to do it, because this sort of thing is something, and that remains a huge problem in urban India. Rural India still has a notional care which needs to be made more comprehensive, but it is there. But in urban area, it's very poor, and that's one of the reasons why it spreads like wildfire in these areas, because the public health measures we tend to lag behind. And we know where to look, but we don't have enough feet on the ground. We have enough engagement with the community, etc. So this is a very good effort, and I hope it sensitizes people to the vastness and the very different ways in which people can make a difference. Thank you.
Right. Thank you. Sita?
Yeah, I would just like to reinforce that vaccines work. They don't have adverse events. And whatever minuscule or occasional sensational stories you hear on television and it's magnified by social media, please ignore them. Please advocate for vaccines. Fight to get vaccines in your areas. Make sure not just your friends, but your mates, people who work with you, the poorer sections of society, everybody gets vaccinated. Contribute in any way you can to the vaccine effort. That is the best we can do to get rid of this in the long term.
Dr. Dere, would you
Yeah, thank you.
give you on the
Uh,
vaccines?
Vaccines, undoubtedly, Madam has said. So I would add to Madam, please, not only social media, please stop, having faith in WhatsApp University. WhatsApp University has really given a, bad image, bad understanding the citizens of this country. Somewhere, you all know there is no other. I always, advocate. Mostly I'm on electronic media. I always say there is only one hope: get rid of this pandemic, is vaccination. Do not stress on that 0.1% anaphylaxis which you get out of 10 lakh people, but always keep into mind 9 lakhs 99,000 we are people are saving. So that taraju is there, is always positive for vaccine, and there is no alternative. Even you so the whatever treatment we are giving, it's just a symptomatic hai, and किसी ने कुछ बोला और किसी ने कुछ दिया है, but the research says somewhere. So one sentence or one thing I would brief of: vaccine is only the hope for this pandemic, and there is no other alternative. And as far as the viruses are concerned,
Make it
viruses,
simple. Make it
yeah,
simple.
yeah,
Make it available.
yeah,
And make it, everyone, let it go right up to the clinic, right up to the society level. And with
yeah.
all the due precautions, of
Yes,
course.
sir.
That's the only solution.
I would only say there is no other option than vaccine. All the citizens, maybe healthcare workers, frontline workers, do get vaccinate yourself to save yourself, your family, Mumbai, Maharashtra, and our great nation. Okay.
Thank you. Thank you very much. Thank you, all of you, to attend this seminar. As you can see that we have chosen the right people who should be giving their knowledge and their experience to you to understand what is happening in India now. Thank you very much again.
Thank you, sir.
I couldn't introduce our fourth panelist, who is Mrs. Indrani Malkani. She's the Ashoka Fellow, and she's taking all the notes. She heads the citizens group, which engages with the government, which is so important. Citizens' voice has to be heard, and it has to be the citizens need to engage with the government, and the government should encourage such engagement. With these words, I thank you all again, and let's
Thank you.
say goodbye.
Thank you.
Bye to everyone. Thank you.
Bye.
Bye.
Thank you.